Patient's here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, and she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
You know, I was actually thinking the other day about the appeal of the orthopedic floor.
Oh, really? Orthopedics?
Yeah, orthopedics. Like, there is this expectation of just, well, absolute precision in orthopedics. It's almost like human engineering.
Right. It's very mechanical.
Exactly. You have a patient who, I don't know, fell off a ladder and their arm hurts. So you order an x-ray and you get this stark black and white image. There's a jagged white line right across the radius. The doctor points at it. The nurse points at it. The patient looks at it. Broken.
Indisputable.
Right. The intervention is clear. The timeline for healing is, relatively predictable. And everyone goes home feeling like they solved a tangible puzzle.
It is incredibly comforting to have a visual confirmation of suffering. I mean, our entire medical model is built on that exact premise. We like things to be visible, to be neatly categorized in a lab value or an imaging scan, because it gives us a clear enemy to fight,
But then, and this is what we're getting into today, you step off the med-surg or ortho floor and you walk into the psychiatric unit. Or maybe you're in the ER dealing with someone who just survived a horrific assault. Suddenly, that x-ray machine is entirely useless.
Completely useless.
We're looking at a diagnostic landscape where the fracture is entirely invisible. The pain is systemic, the vital signs might be completely normal, but the person sitting on the bed is fundamentally shattered. And as a nurse, trying to figure out where to even begin your assessment feels like navigating a minefield blindfolded.
It really does. And that is the daily reality of psychiatric nursing. You are walking into a room to treat a human being whose entire physiological and psychological baseline has been altered by an event. And the only tools you have to locate that invisible fracture are, well, your communication skills, your observation, and your clinical judgment.
Which is a lot of pressure.
Massive pressure. Because trauma is a profound physiological disruption, and it does not respect unit boundaries. A nurse is going to encounter this everywhere, in labor and delivery, in the ICU, in outpatient clinics.
And that is the exact reality we are tackling today. If you're joining us, welcome to the deep dive. We are taking a really dense, layered textbook chapter on trauma and stressor-related disorders, looking at recovery and care and pulling it apart.
And we are not going to just read down a list of symptoms.
No, absolutely not. If you're a nursing student prepping for the NCLEX, or even a seasoned nurse wanting to sharpen your clinical edge, you don't need a textbook read back to you. We are going to apply the 80-20 rule to this material. We are going to hunt for the highest yield 20% of the concepts that will give you 80% of the mastery you need.
The mastery to pass those brutal board questions, yes. But more importantly, to keep your patients safe.
Exactly. Okay, let's unpack this. Safe patient care in this specialty goes way beyond the obvious, doesn't it?
Oh, it goes miles beyond making sure the bed is in the lowest position or like scanning a medication barcode. It's about recognizing the silent behavioral red flags. It's understanding the neurobiology of why a terrified patient might swing at you if you touch their shoulder.
Right, the why behind the behavior.
Exactly. And knowing how to de-escalate that terror using only your voice and their environment. It's about not just reacting to a patient, but actively guiding them back to reality.
So let's start by building a framework. Before we even get into the heavy pathophysiology of what trauma actually does to the brain, we need to map out the non-negotiables. The concepts that, if you encounter them on an exam or on the floor, require immediate reflexive knowledge. Let's start with the biggest trap test writers love to use.
Time.
The calendar. The
Yeah.
calendar is your best diagnostic tool, and it's also your biggest vulnerability on an exam. Test writers know, they absolutely know, that nursing students associate any traumatic event directly with post-traumatic stress disorder.
PTSD is just the buzzword we all default to, right? But the psychiatric framework is highly rigid regarding time. So let's say a patient survives a natural disaster, like a hurricane, and they present to the clinic 2 weeks later. They're experiencing intense flashbacks, severe anxiety, and inability to sleep. You cannot legally or clinically diagnose them with PTSD.
Because 2 weeks is just a normal human reaction to almost dying. I mean, if my house blew away, I wouldn't be sleeping well 2 weeks later either. It seems almost, I don't know, pathologizing to call that a disorder immediately.
It is a profound reaction, yes. But the diagnosis in that specific window between 3 days and 4 weeks post-trauma is acute stress disorder, or ASD.
Okay, so 3 days to 4 weeks is ASD.
Yes. The brain is actively trying to process a massive influx of threat data. The amygdala is firing, the stress hormones are elevated, and the system is overwhelmed. We actually expect that. We label it acute stress disorder to acknowledge the suffering and provide acute interventions. But we wait. We wait to see if the brain can metabolize the trauma or if the condition becomes chronic.
So the timeline for PTSD only kicks in later.
Exactly. Post-traumatic stress disorder requires the symptoms to occur for more than 1 month. And typically, the onset of those symptoms happens 3 months or more after the trauma.
Wait, 3 months? So there's a gap?
There can be.
Yeah.
There can even be a delayed expression where the person seems totally fine for a year, and then some random sensory trigger causes the entire clinical picture to emerge.
Wow.
So on a clinical scenario, if you're taking a test, read the dates carefully. If the crash happened 20 days ago, it is ASD. If the crash happened 6 months ago and the symptoms have persisted for the last 6 weeks, it is PTSD. If you miss that detail on the patient's chart or the question stem, your entire care plan will be misaligned.
That is such a crucial distinction. All right, let's talk about another massive pitfall, and this one happens in real hospitals every single night. The medication management.
Oh, the benzo trap.
The benzo trap. Let's set the scene. It's 2 a.m. on the unit. You have a patient with severe trauma who is weeping, pacing the hallway, visibly jumping at every tiny sound, and they haven't slept in 3 days. The covering provider wrote a PRN order for a benzodiazepine, like lorazepam. Everything in my nursing soul, my absolute desire to relieve suffering, wants to give them that pill so they can finally just get some sleep. Tell me why I need to hesitate.
I get it. Your instinct to relieve suffering is exactly why benzodiazepines are so wildly overprescribed in these scenarios, but they represent a massive safety risk. Let's look at the pharmacology. A benzodiazepine acts on the GABA receptors in the brain. GABA is your main inhibitory neurotransmitter. It essentially acts as a chemical brake pedal.
Right, it slows everything down.
Exactly. When you give lorazepam, you are slamming on the brakes of the central nervous system. The patient will calm down, they will likely fall asleep. In the short term, you feel like you have solved the problem.
But the textbook is incredibly firm that evidence is lacking for their efficacy in PTSD. So what is that brake pedal actually doing to the trauma processing?
It is freezing it in place. Benzodiazepines merely mask the hyperarousal. They do absolutely nothing to treat the underlying neurochemical dysregulation caused by the trauma. More importantly, and this is huge for your exams, tolerance builds incredibly fast.
Because their baseline anxiety is so high.
Yes, and this patient population already has a staggeringly high risk for comorbid substance use disorders as they attempt to self-medicate their intrusive thoughts. Handing them a highly addictive sedative is basically pouring gasoline on a fire. Furthermore, some studies actually suggest that benzos can interfere with the cognitive processing of the trauma.
Meaning they need to process it to heal, and the drug stops them from doing that.
Precisely. The processing is necessary for long-term healing. By over-sedating them, you are preventing the brain from doing the work it needs to do to integrate the memory.
So on an NCLE-X exam, if I see lorazepam or alprazolam listed as a long-term management strategy for PTSD, that is a glaring red flag.
Absolute red flag. Cross it out immediately.
What is the gold standard we should be looking for instead?
You want to look for the SSRIs and SNRIs. Fluoxetine, paroxetine, sertraline, and the SNRI, venlafaxine.
The antidepressants.
Right. These don't just sedate the patient. They actually work to repair the baseline neurochemistry. Trauma depletes serotonin over time, leading to the depressive symptoms, the emotional numbing, and the constant underlying anxiety.
So by using an SSRI?
By inhibiting the reuptake of serotonin, these medications leave more of the neurotransmitter in the synaptic cleft. It allows the brain to gradually rebuild its emotional stability. It's a slow build, but it's a true repair, not just a chemical band-aid.
That makes so much more sense than just sedating them. Okay, moving through our high-yield framework, let's look at the absolute priority when a trauma patient is admitted. We talk a lot about safety in nursing, obviously, but what is the specific life-threatening priority here?
You must assess the risk of suicide and self-mutilation.
First thing.
That is the first action. before you ask about their sleep, before you explore their trauma history, before you even offer a meal. The text highlights that veterans with combat-related PTSD, for example, have a significantly increased risk of suicide, often compounded by those alcohol use disorders we just mentioned.
No, I want to push back on the self-mutilation aspect for a second. If someone is terrified and trying to avoid pain, which is kind of the hallmark of trauma avoidance, why would they actively engage in self-mutilation, like cutting? That feels totally contradictory to the basic human survival instinct.
It seems counterintuitive until you understand the concept of emotional numbing and dissociation. Many trauma survivors experience such overwhelming emotional pain that their brain's defense mechanism simply shuts down all feeling.
Just a complete system override.
Exactly. They describe feeling entirely disconnected from reality, floating, or feeling literally dead inside. Self-mutilation, in many of these specific cases, is not an attempt to die. It is a desperate attempt to feel something, anything.
To break through the numbness.
Yes. The physical pain of a cut cuts through the dissociation. It releases endogenous endorphins and provides a sharp, anchoring sensation that essentially proves to them they are still real, that they are still in a physical body.
Oh, wow. They are using physical pain as an anchor to reality because the psychological void is so terrifying.
Precisely.
That completely shifts how a nurse should view that behavior. It's not mere attention-seeking, which is a label that gets thrown around way too much. It's a maladaptive survival strategy.
It's an attempt to self-regulate when all other tools have failed.
Which leads directly into how we communicate. If someone is dissociating, floating away from reality, how do we bring them back without them having to resort to self-harm?
We use grounding techniques. This is a foundational nursing intervention for trauma. I cannot stress this enough for your clinical practice. If a patient is actively dissociating or having a flashback, their amygdala, which is the fear center of the brain, has completely hijacked their prefrontal cortex.
The logical part of the brain.
Right. The logical thinking part of the brain is essentially offline, and the amygdala does not have a sense of time. To the amygdala, the traumatic event isn't a memory. It is happening right now in that hospital room.
So if I walk in and say, calm down, you're in the hospital, their brain isn't even processing those concepts?
Not effectively, no. The words are just noise. You have to force the brain to process immediate, safe, present moment sensory data. You ask them to engage their five senses.
Give me an example of what that sounds like.
You say, feel the weight of your feet on the floor. Tell me 3 things you can see in this room. Listen to the hum of the air conditioner. By forcing them to process real-time sensory input, you are literally dragging the prefrontal cortex back online and interrupting the internal playback loop of the trauma.
And the text gives a very specific warning here about physical touch during a flashback. My human instinct, if I see someone crying in a corner, is to put a hand on their shoulder to comfort them. Why is that the wrong move?
Because if their brain believes they are currently in the middle of a war zone or an act of assault, an unexpected hand on their shoulder is interpreted as a physical attack.
They don't see a nurse, they feel an attacker.
Exactly. They will react with primal self-defense. You could be struck, or you could severely re-traumatize the patient. You must use your voice, use their environment, and never, ever force a dissociating patient to stand or move if they haven't initiated it. Keep your distance, lower your physical profile, and use verbal grounding.
That is a perfect transition into looking at what actually causes this level of neurological hijacking. Let's dive into the core pathophysiology. The text gives a very specific, almost legalistic definition of what constitutes clinical trauma, because it isn't just a stressful life event like getting fired or going through a bad divorce.
The clinical threshold is very high. Trauma, in this context, is exposure to actual or threatened death, serious injury, or sexual violence. It is an event that poses a profound existential threat to a person's bodily integrity or life.
But it doesn't always have to happen directly to the patient, right? The text outlines 4 different pathways to exposure.
Yes. The most obvious is direct experience. The trauma happens to you. The second is witnessing the event occur to others in person.
Like seeing a terrible car accident.
Yes. The third is learning that a violent or accidental traumatic event occurred to a close family member or friend. And the fourth is incredibly relevant to the nursing profession and the listeners here today, repeated or extreme exposure to aversive details of a traumatic event.
Like first responders, police officers investigating child abuse, or ICU nurses during a mass casualty event.
First responders, forensic nurses, emergency room staff. When you are repeatedly exposed to the graphic aftermath of violence, your nervous system absorbs that threat data. It's often referred to as vicarious trauma. and it can absolutely trigger the full diagnostic criteria for PTSD.
I always found it confusing why the brain reacts this way. I mean, if human beings evolved to survive dangerous environments, saber-toothed tigers, rival tribes, whatever, shouldn't our brains be perfectly equipped to process trauma, learn from it, and move on? Why does the system break down and fragment like this?
That's a great question. In a normal stress response, your body releases cortisol and adrenaline, you fight or flee, you survive, and then your parasympathetic nervous system kicks in to calm you down. The hippocampus, think of it as the memory librarian of the brain, takes the terrifying event, puts a timestamp on it, and files it away in the past.
Okay, so the librarian files it away.
Right. But in profound trauma, the sheer volume of stress hormones essentially short-circuits the hippocampus.
The librarian gets knocked out?
The librarian is completely incapacitated, the files are dropped on the floor, so the memory is never time-stamped as past. It remains fragmented, stored as raw sensory data, the smell of smoke, the sound of a certain voice, the feeling of panic, and it just sits in the amygdala.
So months later, when the person smells smoke, the brain doesn't say, oh, that reminds me of the fire.
No. The brain says, we are on fire right now, and launches the entire physiological survival cascade. That is why the defense mechanisms are overwhelmed. The usually integrated functions of consciousness and memory are totally shattered.
That fragmentation is terrifying, and we see it present very differently depending on the age of the patient. Let's look at pediatric trauma, because the developing brain handles this short-circuiting in very unique ways. The text talks about grossly pathogenic care, which is a chilling phrase.
It really is. It refers to severe neglect, abuse, or institutionalization before the age of 5.
And this leads to 2 highly testable pediatric diagnoses on the NCLEX: reactive attachment disorder, or RAD, and disinhibited social engagement disorder, DSED.
These 2 disorders represent the 2 extreme poles of how a child's brain attempts to survive a complete lack of safe caregiving. You have to remember, in the first 5 years, a child's brain is heavily reliant on attachment to regulate their own nervous system.
They literally borrow the adult's nervous system to calm down.
Exactly. If the caregiver is absent, abusive, or constantly changing, the child has to adapt to survive.
So how does RAD, reactive attachment disorder, look on an assessment?
A child with RAD has essentially learned that the world is a cold, unresponsive place, and that adults absolutely cannot be trusted to provide comfort. So their defense mechanism is complete withdrawal.
Like a turtle pulling into its shell.
Yes, they exhibit minimal social or emotional responses to others. If they are hurt or frightened, they do not seek out a caregiver for comfort. And if comfort is offered, they do not respond to it. They often lack a positive affect and may appear sad, irritable, or afraid even during non-threatening interactions. The attachment dial is turned completely to 0.
They've built an impenetrable wall to protect themselves from further disappointment. It's heartbreaking. But then you have DSED, disinhibited social engagement disorder, which looks completely different on the surface but stems from the exact same root of pathogenic care.
With DSED, instead of withdrawing, the child's boundary system is completely chaotic. They exhibit unselective socialization. This is the child who has 0 hesitation approaching strange adults.
So what does that look like in reality?
It's the 4-year-old who will wander off with a total stranger in a grocery store without checking back with their caregiver even once. They lack the normal, healthy, stranger danger anxiety that protects children.
It's almost like they are so starved for any kind of attachment that they will indiscriminately seek it from anyone, regardless of the safety risk.
They're basically throwing a net out to the entire world, hoping someone, anyone, will act as a regulating caregiver. It makes them incredibly vulnerable to further abuse. On an exam, differentiating between the withdrawn, avoidant child with RAD and the overly familiar, boundaryless child with DSED is a classic test of your pediatric psychiatric knowledge.
Let's pivot back to adults and talk about another differential diagnosis that can be tricky. We mentioned acute stress disorder earlier, but what about adjustment disorder? The textbook places this in the same stressor-related category, but it feels fundamentally different than PTSD.
It is. Adjustment disorder is a disproportionate reaction to a stressful event, but the event itself does not have to meet that extreme criteria of threatened death or serious injury.
So it could be like getting fired.
Right. It can be a severe financial ruin, a devastating breakup, or being diagnosed with a chronic illness. The symptoms, which can include depression, anxiety, and conduct issues, develop within 3 months of the stressor and usually resolve within 6 months once the person adapts to the new reality.
I was thinking about this when preparing for this discussion. Differentiating adjustment disorder from PTSD feels like the difference between a sprained ankle and a complex Malunian fracture.
I like that. Let's expand on that analogy because it works neurologically as well.
Okay, so with a sprained ankle, which is adjustment disorder, you step off a curb wrong. It's a normal life hazard. Your ankle swells up, it is incredibly painful, and for a few months, it severely limits how you walk through life. You might need crutches, you might need some physical therapy, but the bone structure is fundamentally intact. With time, rest, and support, the ligament heals, and you go back to your baseline. The injury resolves.
But PTSD is the complex fracture. A massive external force has shattered the bone into multiple pieces. If it is not surgically set through intense, structured therapy, it heals incorrectly. The bone fuses in a distorted way.
And the pain becomes chronic.
Chronic, systemic, and it permanently alters your gait. You start compensating by putting weight on other parts of your body, which leads to secondary injuries like severe depression or substance use disorders. Adjustment disorder is a painful adaptation to a new reality. PTSD is a physiological failure to process a catastrophic reality.
So, knowing that the foundation is cracked, let's explore who is most likely to suffer that complex fracture. Why do two people go through the exact same terrifying car crash and only one develops PTSD?
This is a profound area of research. Obviously, the severity of the trauma and the proximity to the event are major factors, but the pre-trauma vulnerabilities are what really set the stage. The text outlines that individuals with a lack of social support, a history of previous psychiatric illness, or certain personality traits are at higher risk.
What about military populations?
In the military, being a non-officer rank, having lower education, and the sheer number of deployments multiply the risk exponentially.
It almost sounds like a diathesis stress model. If you are already running on empty, socially, financially, or emotionally, your resilience reserves are depleted when the massive stressor hits.
That is precisely the mechanism. But we also have to look at what happens during the trauma. The text points to peritraumatic dissociation as a massive red flag.
I want to understand this. Peritraumatic dissociation means dissociating right in the middle of the event, like while it's happening.
Yes. If, during the assault or the accident, the person's brain decides the physical reality is simply too horrific to endure, it triggers dissociation. The person feels like they're floating above their body watching it happen to someone else, or the world becomes muffled and slow. And that's bad for long-term recovery. Terrible for it. While this protects their conscious mind in the moment, it guarantees that the memory will not be processed normally. It ensures that the sensory data bypasses the hippocampus and gets jammed in the amygdala, setting them up almost inevitably for PTSD.
The brain saves them in the short term, but creates a chronic illness in the long term. And we saw this on a massive scale with COVID-19, which the textbook explicitly addresses. The pandemic wasn't just a physical virus, it was a mass psychological trauma.
Absolutely. For healthcare workers, first responders, and those who experience severe hospitalizations, it met the exact criteria for trauma. The constant threat of death, the witnessing of mass casualties, the extreme exposure to aversive details, it was a perfect storm.
Not to mention the isolation.
And furthermore, the text highlights the secondary trauma experienced by the spouses and children of these workers. Trauma is not an isolated event. It is contagious within a family system. A severely traumatized, hypervigilant parent alters the neurodevelopment of their children.
So we know who is at risk. Now we need to know what it looks like when they finally seek help. The text categorizes the clinical presentation of PTSD into 4 specific symptom clusters. Let's break down the why behind each of these 4 categories, because memorizing a list is useless if you don't understand the mechanism. The first is intrusion.
Intrusion is the involuntary re-experiencing of the trauma. This is the flashbacks, the recurrent, terrifying nightmares, the intrusive images that just pop into the mind during the day.
This goes back to what you said about the memory not having a timestamp. The brain isn't choosing to remember. The amygdala is throwing raw data at the consciousness, screaming that the threat is active.
Exactly. The brain is trapped in a neurobiological time loop.
The second cluster is avoidance, which makes perfect logical sense. If my brain is constantly forcing me to re-experience the worst day of my life every time I hear a siren, I am going to stop going anywhere near roads. I will isolate myself, avoid people, avoid certain conversations.
Avoidance is an exhausting full-time job. The patient is expending massive amounts of energy trying to build a fortress around their triggers. They might refuse to go to work, refuse to sleep in their own bed, or turn to substances to avoid their own thoughts.
The third cluster is negative cognitions and mood.
This is where we see the memory gaps, but also these profound shifts in how they view the world. The text mentions persistent negative beliefs like, I am permanently broken, or the entire world is dangerous.
This cluster is devastating because it destroys the patient's identity and relationships. You see severe survivor's guilt. You see an inability to experience positive emotions. The patient feels alienated, detached, and incapable of love. Their worldview has collapsed. They cannot trust anyone, including themselves.
And the final cluster is marked alterations in arousal and reactivity, the hyperarousal.
The nervous system is just stuck in overdrive.
Exactly. The baseline is a constant state of fight or flight. You see severe insomnia, reckless behavior, irritable outbursts, and a wildly exaggerated startle response. If a nurse accidentally drops a clipboard in the hallway, this patient might dive under their bed, heart racing at 140 beats per minute.
To quantify all of this, the text highlights specific screening tools like the LEC-5, the Life Events Checklist, and the PCL-5, the PTSD Checklist. These aren't just arbitrary questionnaires. They force the clinician to capture the full scope of the trauma and measure the severity of the symptoms over the past month. It takes this murky, invisible fracture and starts to put some measurable parameters around it.
Which is essential for establishing a baseline. You cannot know if your nursing interventions or your medications are working if you haven't objectively quantified the severity of their hyperarousal or avoidance at admission.
Let's put this into practice. Let's look at the textbook's clinical judgment case study involving JG. I want to really take our time with this because this is where the rubber meets the road.
Let's do it.
JG is a 20-year-old college student. She was sexually assaulted 2 years ago. Assessment data says she used to be highly socially active, but now she refuses to go out. She stays in her apartment. Her friends have abandoned her because she is constantly irritable, and her mother is incredibly frustrated, telling JG to just get over it and go back to living her life. JG reports that she feels entirely alienated and that no one understands her.
Let's pause right there and look at the social dynamics. We have profound avoidance. She won't leave her apartment. We have negative cognitions, alienation, and irritability. But the most dangerous element here is the collapse of her support system.
Her mom is essentially making it worse.
Exactly. Her friends are gone, and her mother's response is actively invalidating her reality. Telling a trauma survivor to just get over it reinforces their core belief that they are fundamentally broken and alone.
The physical assessment data is even more concerning. JG has terrible insomnia. She is terrified to fall asleep because she relives the attack in nightmares, waking up in a panic with tachycardia and diaphoresis. During the day, she suffers from intrusive memories and flashbacks. She has entirely lost her appetite, has dropped a significant amount of weight, her class attendance is practically zero, and she quit her job so she wouldn't be fired for poor performance.
This is a cascading systemic failure. If you are the nurse assigned to JG, you have to prioritize her problems using both Maslow's hierarchy of needs and psychiatric triage. Where does your mind go first?
My mind goes straight to exhaustion and starvation. If she is terrified to sleep and has lost her appetite to the point of significant weight loss, her physical baseline is crumbling. We are talking about severe sleep deprivation and nutritional deficits. You can't expect a patient to engage in intense trauma processing therapy or learn new cognitive coping skills if their prefrontal cortex is starved of glucose and they haven't had REM sleep in weeks.
That is an excellent clinical insight. Physiological stability is the prerequisite for psychiatric healing. However, simultaneous to that, what is the invisible red flag you must rule out immediately?
Suicide. She is isolated, exhausted, feeling burdensome to her mother, and trapped in a mental loop of terror. The risk for suicidal ideation is astronomical. We have to ask her directly. JG, with everything you are carrying right now, are you having thoughts of ending your life? Do you have a plan?
You must ask the direct questions. Don't dance around it. Once safety is established and we begin addressing her sleep and nutrition, perhaps through the cautious use of a non-addictive sleep aid like trazodone, and offering high-calorie, easily tolerated foods we have to look at the milieu management. How do we intervene when she is having a daytime flashback?
We talked about this briefly, but I want to dive into the exact therapeutic communication. The textbook offers a very rigid script for grounding. Let's role play this. I walk into JG's room. She is huddled in the corner, her arms wrapped around her knees, rocking back and forth, staring blankly at the wall. She is actively reliving the assault. I do not touch her. I lower my body to be less physically intimidating, but keep a safe distance. What do I say?
You use a calm, steady, authoritative, but gentle voice. You say, "Hello, JG. I am here with you. My name is..."
Yeah.
Whatever your name is. You are in the hospital. Today is Wednesday. You are safe now.
why the date and the location? It feels almost robotic.
Because you are providing the X and Y coordinates of reality. Her brain is currently existing 2 years ago in the location of the assault. By stating the date and the location firmly, you are injecting contradictory data into her cognitive loop. You are telling the amygdala that the threat is not present. You might have to repeat this several times.
Just keep repeating the coordinates.
Yes. And once you see her eyes focus on you, you validate the emotion without validating the delusion. You say, I know you are feeling terrified right now, but you're safe in this room.
And then we move to the physical grounding. JG, can you feel the floor under your shoes? Can you tell me what color the blanket on your bed is?
We force the brain to process immediate sensory input.
Yes, you are pulling the prefrontal cortex back online. But part of our nursing intervention also involves education. We have to teach JG how to do this for herself. We have her keep a log of her feelings.
Why a log? When someone is suffering that much, doing homework seems tedious.
Because flashbacks and panic attacks rarely happen from a baseline of 0. There is an escalation. The anxiety moves from a 2 to a 4 to a 7, and then the flashback triggers at a 10. The log teaches JG to recognize what a 4 feels like in her body. Maybe her chest gets tight. Maybe her hands get cold.
Oh, I see. Early warning system. Exactly. If she can identify the physiological escalation at a 4, she can deploy her grounding techniques, put on music, or go for a brisk walk to burn off the adrenaline before the amygdala completely takes over. She moves from being a passive victim of her brain to an active manager of her nervous system.
That shift in terminology is something the text emphasizes heavily, the shift from victim to survivor.
It is a critical paradigm shift in therapeutic communication. Victim is a word that implies helplessness. It implies that the event destroyed the person and that they are forever defined by what was done to them. Survivor implies endurance. It acknowledges the horrific nature of the event, but centers the patient's strength in living through it. It fosters self-esteem and resilience.
And we absolutely must avoid the toxic positivity that often slips into nursing care when we feel helpless. The platitudes. I hear nurses say things like, well, you survived, so you should be grateful you're alive, or God doesn't give you more than you can handle, or everything happens for a reason.
Those phrases are deeply destructive. If a patient is drowning in survivor's guilt, wondering why they live when a friend died in the same crash, telling them to be glad they're alive, induces massive shame. It tells them that their pain is unacceptable. It instantly shuts down the therapeutic relationship.
Because it's really about the nurse's discomfort, not the patient's healing.
Exactly. Our job is to sit in the darkness with them, not to artificially turn on a light and tell them everything is fine. You acknowledge the pain. You say, this is incredibly hard, or you are carrying a heavy burden.
Let's expand on the formal therapies that exist alongside our nursing interventions. If JG stabilizes, what kind of structured psychological work is she going to encounter? The text mentions cognitive behavioral therapy, prolonged exposure, and cognitive processing therapy.
Cognitive behavioral therapy, or CBT, focuses on identifying and restructuring those negative cognitions. The therapist helps the patient recognize the distorted thoughts like, I am completely ruined, and gently challenges the evidence for those thoughts. Prolonged exposure therapy is more intense. It involves gradually and safely exposing the patient to the memories and trauma reminders they have been avoiding.
Basically exposing them to the memory over and over in a safe environment until the amygdala gets bored with it and stops sounding the alarm.
That's a colloquial but accurate way to look at it. You habituate the nervous system. And for military populations, the text mentions adaptive disclosure. This is fascinating because it specifically targets moral injury.
Moral injury, that's a heavy term.
It is. Moral injury occurs when a soldier does something or fails to do something that profoundly violates their own moral code. Adaptive disclosure often uses the empty chair technique, where the patient speaks to an empty chair as if the person they harmed or the person they couldn't save is sitting there. It allows them to process guilt and seek imagined forgiveness, which is a powerful release for survivor's guilt.
All of this therapy requires immense cognitive energy. Which brings us back to the pharmacology. We touched on the SSRIs and the benzotrep earlier, but let's dive deeper into the medications used for symptom management. You mentioned SSRIs stabilize the neurochemistry, but what about the really severe, aggressive hyperarousal, the patient who is punching holes in the wall because their startle response is so extreme?
For severe, treatment-resistant hyperarousal, intrusive thoughts, or transient psychotic symptoms related to the trauma, the text indicates the use of atypical antipsychotics, specifically risperidone.
Risperidone is usually used for schizophrenia or bipolar mania. How does it help PTSD?
In lower doses, Risperidone helps dampen the extreme dopaminergic and serotonergic overactivity in the brain. It essentially lowers the volume on the brain's reactivity. It doesn't treat the core depression, but it can stop the aggressive outbursts and the severe hypervigilance, making the patient safe enough to engage in therapy.
But there are risks.
Absolutely. As a nurse, you must monitor for the metabolic side effects of atypical antipsychotics. You're looking out for weight gain, dyslipidemia, and the risk of extrapyramidal symptoms, though the risk is lower than with typical antipsychotics like haloperidol.
I want to transition into an area that feels like the deep end of the psychiatric pool. We've talked about hyperarousal and flashbacks, but sometimes the brain's defense mechanism goes in the complete opposite direction. It doesn't just loop the memory, it completely severs consciousness. Let's explore the dissociative disorders.
Dissociation is the ultimate subconscious defense mechanism. When the physical body cannot escape a horrific reality, the mind escapes. It detaches the emotional self from the physical experience to protect the psyche from total annihilation.
It makes sense in the moment.
Right. While it is a brilliant survival mechanism in the moment of trauma, it becomes a severe pathology when the brain continues to use it as a default response to any stress in daily life.
The textbook outlines 3 major categories. The first is dissociative amnesia. Now, this isn't just forgetting where you put your keys.
No, this is an inability to recall important personal information, almost exclusively of a traumatic or stressful nature. The memory is fully formed and stored in the brain, but the conscious mind is entirely blocked from accessing it. The anxiety associated with the memory is so high that the brain refuses to unlock the door.
And this category includes something called a dissociative fugue, which sounds like something out of a movie, but is a real clinical phenomenon.
Very real. A fugue state is sudden, unexpected travel away from one's customary home, accompanied by an inability to recall one's past and confusion about personal identity.
Wait, they just leave?
They literally leave. The person might assume a new name, get a new job in a new city, and have zero memory of their previous life. The mind hit the ultimate reset button to flee an unbearable stressor.
Then we have Dissociative Identity Disorder, DI, which most people know by its old name, multiple personality disorder. The text is very clear that this is almost always rooted in severe, repetitive childhood trauma, usually horrific abuse.
Yes, in a developing child, the core identity is still forming. If the child is subjected to unbearable, inescapable abuse, the mind fractures. It creates distinct personality states or alters to hold different aspects of the trauma. One alter might hold all the anger, another might hold the terror, while the host personality remains completely unaware of the abuse so they can function in daily life. On assessment, you see severe memory gaps, time loss, and the client referring to themselves in the plural.
The third disorder in this category is depersonalization or derealization disorder. We mentioned this briefly, but it's crucial to understand the distinction between this and psychosis.
Depersonalization is the persistent feeling of being detached from one's own body or mental processes. The patient might look in the mirror and feel like the face looking back isn't theirs, or feel like they are floating above the room watching themselves. Derealization focuses on the outside world. The environment seems foggy, two-dimensional, or dreamlike.
But they are not psychotic.
That is the critical distinction for your nursing assessment. A patient with schizophrenia who is hallucinating believes the hallucination is real reality. They have lost reality testing. A patient experiencing depersonalization knows that their perception is distorted. They will say, I know I am real and I know this is a hospital room, but it feels like I am in a dream and my hands don't belong to me. They are deeply distracted by the distortion precisely because their reality testing is intact.
Now, navigating these dissociative amnesias brings us to one of the most intense clinical controversies mentioned in the text, false memory syndrome. This is an incredibly delicate ethical and clinical tightrope.
It is arguably one of the most difficult situations a psychiatric nurse or therapist will face. The controversy centers around the recovery of repressed memories during intense psychotherapy.
On one hand, we know that the brain absolutely can suppress horrific memories to survive. We know repressed memory is a real neurobiological phenomenon.
We do. But on the other hand, the human memory is not a video recording. It is highly malleable, highly suggestible, and constantly being reconstructed. The concern is that a highly vulnerable, severely anxious patient who is desperate for an explanation for their pain might enter therapy. If the therapist uses highly suggestive techniques, hypnosis, or leading questions, the patient's brain might actually construct false memories of childhood abuse that never happened.
And the devastation that causes is immeasurable. Families have been destroyed by groundless accusations, but if the clinical community swings too far the other way and becomes inherently skeptical of all recovered memories, we end up gaslighting and silencing actual survivors of horrific abuse. We leave them totally alone.
Which is why the nursing approach must be so rigorous. We do not play detective. If a patient begins to recall a traumatic memory on the unit, our job is not to interrogate them for proof, nor is it to blindly confirm the details of the memory. Our job is to validate the emotion and manage the distress.
Keep them grounded in the present.
Yes. You treat the profound terror and anxiety the patient is experiencing in the present moment. You maintain a supportive, neutral, non-leading stance. You say, I can see how terrifying this memory is for you. I am here to help you stay safe right now.
You treat the physiological response in the room, regardless of the historical accuracy of the trigger. That is excellent clinical boundaries. Okay, we have covered an immense amount of complex neurobiology, pharmacology, and therapeutic communication. I want to bring all of this together in our final segment. Let's do a rigorous NCLEX and clinical logic synthesis. I'm going to throw realistic board-style scenarios at you, and I want you to break down exactly why the right answer is right and why the distractors are wrong. Ready?
I'm ready. Let's dissect the exam logic.
Scenario 1. A patient is admitted to the psychiatric unit after surviving a severe house fire 2 weeks ago. They report terrifying nightmares, hypervigilance, an exaggerated startle response, and they refuse to talk about the fire. The nursing student documents a suspected diagnosis of post-traumatic stress disorder. Why will this documentation be flagged by the clinical instructor?
Because the timeline is wrong. The student has fallen for the classic distractor. The trauma occurred 2 weeks ago. The diagnosis must be acute stress disorder. PTSD cannot be diagnosed until the symptoms have persisted for more than 1 month. The correct nursing action is to document the symptoms and monitor the progression, knowing that this is an acute phase.
Scenario 2. You walk into a patient's room. The patient has a known history of severe combat trauma. They're crouched in the corner of the room, holding a plastic knife from their lunch tray, staring wildly at the door and yelling for their squad mates to take cover. What is your absolute first nursing intervention? Is it A, step into the room and gently take the knife from their hand? B, call for hospital security to restrain the patient? C, stand in the doorway, use a calm voice, and orient the patient to their name and location? Or D, administer IM haloperidol?
The answer is C. Stand in the doorway, use a calm voice, and orient the patient to their name and location.
Why not A? They have a potential weapon.
If you step into the room and try to take the knife, you're entering the delusion of a patient who believes they are in a combat zone. They will likely perceive you as an enemy combatant and attack. You become a casualty.
Why not B? Call security.
Security and restraints are the absolute last resort, the most restrictive intervention. The sight of uniformed guards rushing the room will massively escalate the trauma and confirm their belief that they are under attack.
And D, the chemical restraint.
Again, highly restrictive, requires an order, and does not address the immediate de-escalation needs. You must try verbal XY coordinate grounding first from a safe distance. You are in the hospital. Today is Tuesday. You are safe.
Perfect. Scenario 3. A patient with PTSD is being discharged. The provider has prescribed fluoxetine 20 milligrams daily and lorazepam 1 milligram PRN for severe panic attacks. During discharge teaching, the patient says, I'm so glad I have the lorazepam. My friend says it cures PTSD in a few months. What is the priority nursing response?
You must correct the misunderstanding regarding the pharmacology immediately. The priority response is to educate the patient that fluoxetine is the medication that treats the underlying neurochemical imbalance of PTSD over the long term. You must explicitly warn them that lorazepam is only for short-term, acute symptom relief, that it carries a high risk of tolerance and dependence, and that it does not cure the disorder. If you let them leave believing that benzo is the cure, you are setting them up for a severe substance use disorder.
Final scenario. A patient who survived a horrific car accident that killed their spouse is crying in the day room. They say to the nurse, it's entirely my fault. I shouldn't have suggested we drive that night. I deserve to be dead, not him. Which response by the nurse is the most therapeutic? A, you survived, and your husband would want you to live a happy life. B, everything happens for a reason, even if we can't see it now. C, you couldn't have known the accident would happen. You have to forgive yourself. Or D, it sounds like you are carrying a tremendous amount of pain and survivor's guilt right now.
The correct answer is D.
Let's break down the toxic distractors.
Answer A tells the patient how to feel and invokes the deceased husband to induce guilt. Answer B is the ultimate toxic platitude. It is dismissive and philosophically unhelpful. Answer C is argumentative. You are arguing with their core belief, which they will resist. Answer D simply reflects their pain back to them accurately. It validates their current emotional state without agreeing with their distorted beliefs that they deserve to be dead. It opens the door for further therapeutic exploration.
That is exactly how you have to think to beat these exams and to be a safe nurse. We have unpacked the timelines, the absolute priority of suicide and safety assessments, the physiological reality of the overwhelmed amygdala, the power of sensory grounding, and the massive dangers of the benzo trap.
It is heavy, challenging material. But understanding the neurobiology behind the behaviors transforms how you look at these patients. You stop seeing a difficult or non-compliant patient, and you start seeing an overwhelmed nervous system trying desperately to survive.
And before we wrap this up, I want to leave our listeners with one final, incredibly profound concept buried deep in the text regarding cultural considerations. It's something that completely reframed how I view psychiatric resilience.
Yes. The text explores the trauma experienced by refugees, people forced to flee their countries because of war, genocide, or political oppression. These individuals endure unspeakable horrors, loss of home, loss of family, and profound alienation in new countries. The expected outcome is a massive rate of PTSD and mental defeat.
But the data reveals a protective factor that isn't a pill and isn't a specific therapy technique.
The text states that refugees who maintain a stronger sense of self and a powerful cultural identity are less frequently diagnosed with PTSD. And if they are diagnosed, they have significantly better long-term outcomes. Their allegiance to their heritage acts as a psychological shield.
I found that endlessly fascinating. In Western medicine, we are so intensely focused on the individual therapy, individual neurotransmitters, individual coping skills. But this source material is suggesting that perhaps the most powerful, untapped defense against the devastation of trauma is community, heritage, and cultural rootedness. The knowledge that you belong to a narrative larger than your own trauma.
It implies that healing is not just an internal neurobiological job. It requires connection to a shared history. A strong cultural identity provides a framework of meaning that the trauma cannot entirely shatter. It's a beautiful reminder that while we treat the biology, we are ultimately caring for human beings who need to belong somewhere.
Exactly. Keep that invisible X-ray metaphor in your mind as you walk onto the unit. The X-ray machine might not show you the fracture, but with the right clinical judgment, the right communication, and a deep understanding of the pathophysiology, you will know exactly where it hurts and exactly how to help it heal. Thank you for joining us on this deep dive. Take this clinical mastery onto the floor, take it into your board exams, and keep looking beneath the surface.